I want to move on to the last topic by the Professor Sumit Sinha from India. And his topic is about surgical minimalism for intracranial lesions. So, Dr. Sinha, are you ready for your presentation?
Yes. Can you see me? Can you hear me?
Oh, of course, perfectly.
Okay. Can you see my slide, Professor Miki?
Yes,
Can you see
of course.
Okay. So, very good evening, everyone. And at the outset, I would like to thank WFNS and Professor Miki, Professor Jalali, for giving me this opportunity to speak on my passion about this minimalism and keyhole endoscopic assisted approaches. Of course, a wonderful anatomical depiction of these approaches and the surgical depiction of these approaches in the previous last two lectures have been given. And my job has been use among these patients with intracranial lesions. I have no financial disclosures. So let's see as to what the keyhole is all about. The keyhole is not about the size. I would like to very clear about it. From the very beginning, it is not about 1 centimeter, half centimeter. It's not about the size at all. It's always a philosophy. It's that minimum size of the craniotomy by which a surgeon is confident as to take out the lesion without damaging the crucial anatomical structures around the lesions. So there are some principles of the keyhole as to how one can achieve that, and this is what is known as the keyhole concept. It is a reverse funnel shaped concept. So in a normal microscopic vision, we see the vision is like this, which is a funnel shaped vision, broader outside, narrow inside, and it is the exact reverse in the case of a keyhole craniotomy. It's the narrow outside and broad and wide vision inside, and hence this keyhole approach is most suited for the tumors that are located deep within the below the skull. So this is the philosophy is about there are certain other principles of a keyhole approach, like, for example, it has to be absolutely precisely placed. It has to be placed with the help of an image guidance system, which is a mandatory apparatus equipment, which is required in fashioning and designing these craniotomies. It is a mobile viewing trajectory, can look from through the keyhole through wide angles of vision from here. The armamentarium is massive. Take the endoscope, you can take the angled endoscope inside. And the best in my subsequent slides, you draw a long axis along the two ends of the tumor and then project that long. This is one of the other principles. Of course, the keyhole is not good at looking at the back of the door. So therefore, this is not a good approach for superficially situated convexity meningiomas and similar other lesions. So having talked about the keyhole approach, this was one such thalamic glioma, which I operated through the keyhole approach. And the long axis principle of this keyhole has been shown, draw a line and then project it to the skull. And this is where you have to enter into the tumor through this keyhole. This is what this illustration shows about. It is so the minimum craniotomy which is required to access a deep intracranial pathology, and endoscopic assistance. It's a wonderful tool through the fully endoscopy as depicted by Professor Goto or assisted endoscopy. I will show you along my subsequent slides. Used to visualize around the corners and these keyhole can work magic and wonders with surgery. So the SOCA approach, the supraorbital keyhole approach for BSN, of course, and above the orbital roof. The lesions below the orbital roof, then nest regions, and this is one olfactory groove, and sphenoidally meningiomas are some such tumors which are SOCA approach, and of course clipping of the anterior communicating artery segment aneurysms also in the cold phase. I would say not in the acute rupture phase. They are good to to remove through the SOCA approach. Another example of planar meningioma removed through a keyhole approach, pre-op and the post-op complete tumor removal. And this is what the endoscope at the end on during the surgery is taken inside and see the remnants of the tumor tissue. Angled scope, it causes beautiful complete excision of the tumor. And this is what the cosmesis of this beautiful approach is all about. The scar is barely visible even 3-4 days after the surgery. Another example, mini-terional craniotomy. It's a 3 or 4 centimeter skin incision, 3 centimeter craniotomy. You can see the size 2 centimeter of this massive solid cystic craniopharyngioma, and this is what after the removal of the tumor tissue in the 2 or 3 days after the surgery. This patient with craniopharyngioma was referred to us from outside, and this was an attempted removal of the tumor. We chose to go in again, but through a mini-terional route, and you can see this is a multi-compartmental craniopharyngioma, and we have to issue. You can see the bits and bits of the tumor tissue spread all across, and the brainstem under the panoramic view of the endoscope through the mini-terional craniotomy. So through the visualization of endoscope and a microscope together. So this is a post-operative CT scan. Medial sphenoid wing meningioma, mini-terional craniotomy. Yes, it is very, very doable. Endoscope is used to see the tumor around the optic canal. Sometimes, most of the times, I would say these tumors progress through the optic canal, and they are the major cause of visual deterioration. And this is the crux of this surgery, to deroof the optic canal, remove the tumor there, and so that the patient gets the benefit of return of the this is the tumor tissue, which is very, very densely adherent to the carotid artery. You can see over here, and all this is done through a keyhole approach, and sharp dissection of the tumor tissue, sharp dissection separating the tumor tissue from the optic nerve, and there you see the arachnoid down below with the posterior communicating artery will be soon seen. Taking care not to pull carotid communicating artery there, the tumor completely separated from the optic nerve, and this is what it is. A small portion of the tumor tissue is still attached to the carotid over here, and an attempt is through the sharp dissection. There is a small plane of arachnoid over here, and we should respect this plane of arachnoid over the carotid artery, cut into this plane of arachnoid, and then we can be able to separate the entire tumor tissue from the carotid artery. So this is what you see. There is not even most of the times there is not even the need for putting in a retractor system over the. There is ample space. Once you fashion a keyhole craniotomy, enter inside. I always advocate to wait for about some. That's the another thalamic glioma, pre-op and the post-op, and this is the patient immediately after surgery, which is intact.
किस राज्य में है ये?
Intact, and this is another medial tentorial meningioma, which is removed through the keyhole craniotomy, and this is what the trajectory of the approach is. You draw a long axis where it crosses the skull. That's the entry point of your keyhole. And this is the immediate post-operative CT scan of the patient. Falcotentorial meningiomas, they can be, if the craniotomy is properly designed, and then you can take care of these formidable tumors through the keyhole. It's a 4 centimeter long craniotomy, the Poppins approach, and all the principles are the same as a conventional in posterior intrahemispheric approach. This is the tumor tissue. These are the great veins over there where you can see. This is the internal cerebral vein, and the tumor tissue is being slowly separated. The posterior choroidal arteries, sharp dissection, and sharp dissection is the key to wonderful, excellent operative procedure in this area, taking care not to damage this is the third ventricular posterior wall, and this is the immediate post-op CT scan of the patient, the follow-up patient, and this is where we entered into this tumor, and this is the follow-up post-op MRI at 1 year after the surgery, showing complete tumor removal. So a keyhole can work magic if properly placed, if properly designed, if the philosophy of the keyhole is properly followed. Now, coming to the mini subtemporal approach, this is the most important approach for various posterior skull base and middle skull base lesions. Now, coming to the petroclival meningiomas, you see this is one such petroclival meningiomas which I chose to operate through the keyhole subtemporal route. And this is what the post-op CT immediately after the surgery looks like, showing complete excision. This is what the patient had symptoms before the surgery, which persisted for about 6 months, and and you see the patient having completely intact after 1 year of surgery. Petroclival meningioma, another one, you see the size of the craniotomy, and there is absolutely no need for doing a massive skull-based bony work in such tumors, because it is no longer required actually. This is the thing of history. This is being done in the past. Massive skull-based exposures requiring anterior petrosectomy, combined petrosal. Many times during the surgery, after the surgery, for various reasons, inspection or drilling the internal meatus, as you can see in this area, in this video. Drilling of the internal meatus, looking backwards into the yes, endoscope is a beautiful tool, but it's facial nerve beneath the arachnoid over here is stimulable functionally and preserved anatomically. And this is how you can utilize, you see the facial nerve over here. This is how you can utilize your endoscopic tool to your advantage during the surgery. Removal of the tumor from Meckel's cave. The endoscope is a beautiful tool. And in some surgeries, you have to remove the tumor from Meckel's cave because it is symptomatic. Patient presents with trigeminal neuralgia. which is very troublesome to the patient. And you see this tumor tissue inside the Meckel's cave, which is the responsible cause and which needs to be tackled and removed endoscopically during your surgical procedure. And this is the post-op CT. You see that the tumor has been completely removed. Endoscope can be used to visualize the supratentorial structures. As you can see, after the removal of this petroclival meningioma, there is absolute complete removal of the tumor tissue through the keyhole, and you see the sixth nerve, you see the third nerve, the fourth nerve, seventh nerve, lower cranial nerves. All the nerves are structurally, anatomically intact, and then after the removal of the tumor tissue. Acoustic neuroma surgery, lovely surgery, post-operative tumor complete removal under the endoscopic vision from the internal acoustic meatus, as you just saw, and under neuromonitoring, showing intact functional seventh nerve. Preservation of hearing in an acoustic tumor, you see the patient has serviceable hearing after the surgery. This tumor was also done keyhole endoscopic assisted approach, which is very good, beautiful approach in saving the seventh and the eighth nerve. My patients of acoustic neuroma after the surgery, very big tumor, no need to make big craniotomies. You have to be philosophically and functionally correct in operating and designing the craniotomy of such tumors. And you see a small craniotomy, removal of the entire tissue. CP angle epidermoids or epidermoid anywhere, it's a beautiful tumor, and endoscope is used, angle-scope is used to visualize the nooks and corners of these tumors. And surprisingly, many times you find that when you think that these tumors are completely removed, about 20-30%, they are still left in the nooks and corners. And it is this time when you take in the endoscope inside the angled scope and you remove the rest of the tumor tissue from these areas. Petroclival meningiomas through the retrosic route, one such petroclival. Now, I choose the retrosic route in these formidable tumors when majority of the tumor tissue is in the posterior fossa. So this is one such example of this tumor taken through the posterior fossa and through the retrosic route. And this is the patient after the surgery, clinically intact lower cranial nerves, external ocular eye movements, and intact patient after the surgery, and the complete removal of the tumor tissue is achieved simultaneously. So this is how it looks like. Expanded keyhole approaches, one word of mention through the keyhole. These are such approaches where which cross the limits of the retrosic approach. And what we do is we cut the tentorium. Now, these approaches were first described way back by Sami et al. And it's a useful approaches for the tumors which are going beyond the tent into the supratentorial area. This was one such tumor going up into the supratentorial area. This is the immediate post-op CT scan, complete tumor removal, and this is the post-op MRI 1 year after the surgery. And you see during the surgery, the tent is being cut. You can see the sixth nerve over here, complete tumor removal, the tumor bed. This is the occipital lobe, which you can visualize the cutting of the tentorium during the surgery. And you see the fifth nerve and the superior cerebellar arteries after, and the posterior cerebral arteries after the removal of the tumor. Massive giant petroclival meningiomas, keyhole is the answer. No longer combined petrocell approaches. No, you can do it in 2 stages. One stage, the first stage, the subtemporal route after the first surgery can achieve this post-op CT and then do the second surgery, staged second surgery the next day, or maybe staged surgery can remove the complete tumor removal is being achieved now. Another such tumor going into both the middle fossa and the posterior fossa. This patient, this beautiful lady, came to me in November 20. We chose the keyhole subtemporal approach, and this was the end result. And then this was after a year. No, this was after the first stage intact eye movements of the patient, and slight dosage improved gradually after the 6 months. And then this lady came to me after a year after the follow-up, because they went away to the home to make arrangements for the money, which is an obvious reason for people here in this part of our country to arrange for the money, and then they come again for the operation. Now, this is after the second operation, which is the residual tumor after the first surgery. He went through the retrosurgery and removal. This is the follow-up, and 1.5 years after the patient is completely intact after the second surgery. So this is my humble experience over the last 6 years. Mainly, it is in the last 6 years. Overall data for last 10 years, 958 patients. So keyhole approach, all variety, all gamut of intracranial lesions. I have had my share of complications, and I'm still learning. And so in the end, I would like to say that keyhole neurosurgery is a wonderful approach. It is a new perspective. It requires working in a narrow corridor and requires a thorough knowledge of anatomy. It is a less morbid and better option. It is minimally invasive and maximally curative. And massive time-consuming and morbid skull-base approaches are no longer required because keyhole, subtemporal, and retroseg are the workhorse approaches for petroclival meningiomas, for tumors such as PCMs, and they offer complete resection with minimal morbidity. And of course, last but not the least, endoscope is a significant tool which augments the effectiveness of keyhole approaches. Thank you so much.
Thank you, Dr. Sumit. It's very great talk, and all the surgical procedures are very experienced, and I'm very impressed. So I would like to accept some questions or comments from the audience. By the way, I'm moderating this session with Dr. Paolo Cadri, so I'm late for introducing him. So Dr. Cadri, do you have any comments or? Okay. So Dr. Goto, how about you? Professor Goto, do you have any comments?
Yes. Thank you for nice lecture, Dr. Schmidt. You always present a nice keyhole approach. You always start the keyhole approach by the microscope and then switch the endoscope. When you switch the surgical procedure from microscope to endoscope, is there any tip?
Oh, well, I mean, it's a very good question, Professor Goto. Now it's nothing like hard and fast. As to when I want an endoscope, most of the times it is during the surgery when I reach an area where I'm no longer able to visualize through the straight light of the microscope, I feel the need to bring in an endoscope. And unfortunately, I don't have an exoscope right now with me. We are in the process of acquiring one, but then I agree to that this requires a change of entire instrumentation, and some of the time is elapsed in this interchange. So right now I'm not very enthusiastic to keep it changing very frequently. But yes, having said that, I would agree to that once, like for example, if you are operating on a medial sphenoidal meningioma and you want to look under the optic nerve, so at that time, I would like to take my endoscope immediately inside and to see the extent and, if required, the removal under endoscopic assistance. I hope that answers your question.
Thank you.
Oh, any other questions or comments?
Professor Miki, can I ask a question?
Okay, please go ahead.
Professor Sumit and Professor Goto, do you have any experience about vascular surgery with this keyhole approach?
Can I answer first? Okay. Thank you, Dr. Abizar, for that question. Now, through this WFNS symposium, I would like to convey, this is one of my experiences, which I would like to share is, I never operate aneurysms in the acute phase, acute ruptured phase through a keyhole. So I'm not propagating that this is not the right way, but I will like to share the reasons as to why I'm not very preferring to do the acute ruptured aneurysm through a keyhole, because the brain is tight. Now, if I say the brain is tight, this is not an absolute contraindication. Of course, you can make a keyhole. You can, as I said previously, you can slowly go through the cisterns, open the cisterns, drain the CSF, the brain becomes lax in most of the situations. But what is even more daunting is, what is even more dangerous is, many times in the acute ruptured phase, there is massive edema of the brain, which you require a space after your surgery in the post-op. You require a space for the brain, soul and brain, to settle in after the surgery also. So this is the main reason that I don't use my keyhole in these anterior and posterior circulation aneurysms. And it should not be done according to my opinion.
Very interesting. Very interesting. What about you, Dr. Goto?
I usually use a keyhole approach to tumor case, not vascular case. For example, in the aneurysm, we have to wide exposure of the aneurysm. So it means in the vascular case, we cannot perform the internal decompression. But the tumor case, at once we can reach the attachment of the tumor and detach and perform the internal decompression. After that, we can make the space. So we can perform the safe dissection. But vascular disease, it's very difficult to perform or impossible to perform internal decompression. So I usually use a microscopic classical procedure to vascular lesion. This is my strategy. Thank you.
Okay. And one more thing, Professor Goto, and I think that you will also agree upon this. In the tumors, especially in the benign tumors, they make a space for themselves, which work in our favor actually. With a keyhole, you can internally decompress, and when you decompress, you find a whole lot of space inside there.
Yes.
So this is not the case with the aneurysms.
Yes.
Thank you.
Okay, thank you. And this is the last question from the audience. So what about you? Do you use the navigation system? Do you use the navigation system for this keyhole approach? What about you, Dr. Sami?
Yes, absolutely. Navigation system is an absolute mandatory requirement for a keyhole approach. You cannot perform a keyhole approach without a navigation system. The reasons I have elaborated in my talk, because even if you are 2 millimeters away from your target, you will be entirely messing up with your surgery, and you will repent as to why you did made a keyhole.
Thank you. So, Dr. Goto, you agree with that, right?
Yes,
Okay.
absolutely.
Thank you. So thank you for the great talks, and I think it's almost time to close the session. So thank you everybody for joining this session. Thank you. I will close this session.
Thank you.
Thank you all for joining
Thank
us.
you.
And then we will have our next education online symposium on May 11. Goodbye. Goodbye, everybody.
Goodbye,
Goodbye,
Goodbye. See
everybody.
you again.
Thank you.
Bye.